Welcome to the continuing education module, Understanding Health Risk and Health Cost Relationships, why they are so important. Our agenda for this particular continuing education module includes what are the major cost elements of worker health, what determines health costs in any individual and population, summary of early studies that looked at the relationship between health risk and health cost, health risk definitions, major patterns of healthcare use, the HERO study and its comparison with the early studies, newer study results, risk stratification model, and finally a summary of key points. Now let's look at the economics of worker health. And this is the information that essentially senior management in all of business and the nonprofits and governmental need to really understand this data. This is data that is national in scope. It's been derived from two major studies, one published by Ron Getzel, a colleague friend, and the other by Collins with the Dow Chemical presenteeism study. These are some of the better studies that have been done. It's been updated to 2015 by using the Mercer large employer survey, health plan survey results to actually come up with 2015 dollars. And what you see here are, first of all, presenteeism, about $19,000 per employee per year as a typical cost. About $13,000 for the health plan coverage that's been going up at approximately 5 to 6% for a number of years now. That's about twice to three times what our consumer price index is going up, so it still continues to get large and larger in terms of its relationship to other expenditures. About $2,200 for sick leave, $873 for workers' comp, another $1,400 or so per employee per year for disability. So these costs are all per employee per year, and it totals about $37,000 of cost. Now, the items on the left-hand side of the pie chart, those four items, essentially are economic costs that a business encounters. The 19,000, the presenteeism amount, is really lost productivity, and it's the value of lost wages, salary, and benefit costs. So there are other benefits that are affected by our ability to be at work, but to have an underlying health problem which keeps us from being as productive. So that whole field, there's a separate CE module on presenteeism that you can look at that also looks deeper into measurement methodology, the way in which these economic costs can be tracked, and their implications for managers. The amount here of 37,000 is actually a pretty large economic cost, and it's the cost that I believe, and my experience leads me to believe, is really needs to be represented to our senior management staff. And the idea here is that each organization has its own approximate cost for each of these five elements. And the measurement of those and the placement of those and the way in which we deal with those is really what needs to buttress our efforts at funding and doing wellness in a way that's really intended to affect the health improvement needs of these populations and to affect their injury and illness expenses. So it's best if we know the economics of worker health as a larger issue that allows us to talk about wellness in a more strategic vein. Now, the determinants of healthcare use, the work that was done originally by Odin Anderson and his son at the University of Chicago, looked at two different ways of looking at determinants. And it's an economic model. The two ways of looking at this are supply side factors, and those are outside the individual employee or the individual consumer, and demand side factors, which are inside the consumer. So there are a variety of factors. We'll look first at the supply side outside the individual, and then I'll try to describe how those affect healthcare costs. But we call them determinants of healthcare costs for individuals. When we then summarize all those individuals into populations, we then see the collective effects of those factors working their way out. Now, the extent and scope of insurance coverage comes from the work of the RAND Health Insurance Experiment, a major prospective trial, a randomized controlled clinical trial that allowed us to see that if you gave people very rich insurance, they would tend to use more of the services. There would be more utilization, but not necessarily healthier effects or health improvements. They just use more health care. So you see the asterisk that is on this item, and if you look at the bottom of the screen, you will see potentially modifiable by employers. So we, in fact, from the employer vantage point, do reduce the extent and scope of insurance coverage as a cost control strategy. So that's been used for decades now. We also come down to a place where, with the potential repeal and modification of the ACA, we are seeing the movement potentially away from as rich a set of essential health benefits. They're called essential under the ACA, but they really are very generous and very extensive, much more extensive than we essentially need as a nation in terms of guaranteeing healthcare coverage for all of our citizens. Now, point of use cost sharing is another supply side factor that affects how much utilization and cost an individual uses. So if I know that if I go to the emergency room, it's going to cost me $200 out of pocket, I'm going to use an emergency room differently than if it's no additional money out of pocket. So that point of use cost sharing, me knowing what the amount is connected to my choice to use a particular resource, can have a lot to do with how much healthcare use and how much healthcare experience and cost I encounter. Another one of the supply side factors outside the individual is if I'm in a rural area, it's harder for me to access healthcare services, and I have less access to more extensive or comprehensive services. So that location, geographic location, changes my access to services. And if my population that I'm insuring is in a rural area, it will have very different healthcare utilization patterns than if I'm in a suburban or urban area. So that's a factor that affects how much healthcare utilization a specific population needs. Now, another one of the supply side factors that affects healthcare use is the regional or local practice patterns. There are areas of the country where the clinicians have set up standards that are more efficient. They don't use as much in the way of care, and that's days of hospitalization, types of drugs, types of supporting therapies that are used. So those regional and local practice patterns have evolved over the years to have some areas that have very high levels of utilization and others that have relatively low. The work at the University of Vermont and Dartmouth in terms of what's called the Healthcare Atlas and the differences in Medicare expenses by zip code show us that regional and local practice pattern difference. Another one of the supply side factors is there are a number of ways in which the provider, the doctors, the clinics, the specialists or dentists or clinical psychologists have incentives affecting their diagnosis and treatment decisions. And a fundamental issue for our healthcare system is that revenue is the name of the game. Generating revenue is what the healthcare providers and system is there to do. And if they in fact structure incentives or policies that are tending to increase the revenue generation activities, that will affect how much diagnostic and treatment decisions and activity is carried out with a given population. So if for instance, if I'm a physician and I buy a new piece of lab equipment, I'm going to suddenly think that everybody needs to have that lab test done on them. So then I start passing those bills on to the health plans. And unfortunately, there's a lot of areas of medicine where it's a gray area as to whether a specific either diagnostic activity or treatment modality will in fact be helpful to an individual with a particular kind of clinical problem. So there's a lot of gray area. It's not all white and black. It really has a lot of gray area to it. Now let's switch over to the demand side factors from an economic context that are inside the individual. And we're going to look at those across these figures. And what you'll see again is the potentially modifiable nature that's indicated by the asterisk. And the two most powerful factors and variables that affect healthcare utilization are age and gender. And we're going to look at some of that data in a moment that really kind of shows you that. There is a differential use of healthcare between men and women, and there's a differential use associated with the age of the individual. Now, other things that we affect in terms of health of wellness programs, depending on how we've structured our interventions and what kinds of targets we're going after, is we can improve or increase the sense of responsibility for personal health. So if I'm not feeling very responsible for my health and I kind of am fatalistic about it, and I basically don't want to take any responsibility for improving or working on my health, that will affect how much healthcare utilization I encounter or choose to use. Many of the decisions in healthcare come and are originated from consumer action, where the consumer decides to go in and tell the provider, I hurt, or I have a pain, or I'm not sure about this. And then the provider is then in a position to go ahead and decide what diagnostic activities will take place and what treatment follow-up will take place. So there is a strong set of relationships between what the consumer does around healthcare and what the provider does. It isn't all controlled by the provider, and it isn't all controlled by the consumer. Another area where we have data, and this is what we're going to focus on heavily in this module, is the clinical risk factors, and will include the personal health behavior risk factors as well. So those two areas of issues are what we have oftentimes looked at in terms of the relationship of these lifestyle choices or clinical risk factor choices of having high blood pressure or high cholesterol or being obese or dealing with tobacco use or alcohol use or my food choices. Those are all embraced in those two variables, the clinical risk factors and my personal health behavior choices. So those things tend to be associated strongly with healthcare utilization. In addition, the next area is current morbidity. Current morbidity essentially means illness and injury. So that's the unique set of illness and injury realities that come down for each individual, and those are shaped by a large number of variables. But that's the pattern of my past pattern of healthcare. And if you wanted to get an idea of this, you might look back 5 years and think about how much healthcare have you used? Have you been hospitalized? What for? Have you gone to physicians' offices for acute treatment or chronic disease? Have you gone for preventive screening? Have you used a dentist? Have you used an optician, or ophthalmologist? So there's all of this current morbidity, which really is reflected by the unique health characteristics of each individual. The next area on the left of the demand side factors is self-efficacy, and that is a whole area developed by Albert Bandura and some other researchers and scientists, and it essentially deals with how confident am I in making decisions about my health and my family's health. And if I have a high level of self-efficacy, I'm not going to be so dependent on the healthcare system. I'm going to be making decisions for myself. So that self-efficacy is also a very strong element that comes into play in terms of the issues of what do I seek diagnostic help or medical advice or treatment advice about. And then finally, we have a number of attitudes about personal health and healthcare use that are embedded in each individual and in populations. Sometimes they are cultural in nature or subpopulation oriented, so that my ethnicity or my language or my background will also shape certain things about how I perceive my own health, what my responsibilities are for my health, and how I should use healthcare services. So this is a fairly significant a look at what determines how much healthcare you will need during your lifetime in the next year. These are the factors that are going to come together that will, in fact, affect how much healthcare utilization, and that translates into healthcare cost that you will encounter. So in summary, this particular module is going to look more deeply at the clinical risk factors and the behavioral risk factors that are associated with increased levels of healthcare use. Now, this is a listing of the early studies, and these are the seminal studies that have helped us understand the relationship between health risk and healthcare costs. And even with our current day practices of wellness and worksite wellness, we tend to be moving away from the reality of what was found in these studies. All of these studies have found that risk factors of various kinds and behaviors of various kinds, or clinical conditions of various kinds will in fact have an enormous effect on how much health care someone needs and uses. So I've given you some of these studies. We're going to summarize what they found in the next chart, but the idea is that these activities have been going on for some time. Some of them are very large in scope, and they provide us a great deal of useful insight into patterns and trends that are affecting and shaping costs now in today's healthcare marketplace. Now, this is the relationship of health risk to health costs, the early studies. They're numbered according to what you just saw, so those are the citations. There's 1 through 6. There's a weighted average, and we'll talk about that in a moment. It also takes the item or the study or the risk factor, and it shows you which things have been done. And if you look not at the white area, but at the green area above it, you will notice that each of these issues, whether you smoke or not, whether you use alcohol or abuse alcohol, whether you're obese, whether you exercise, whether you don't wear seat belts, whether you have a cholesterol reading that's elevated or a blood pressure that's elevated, whether you're using drugs and medications as a general rule, your stress levels, and your eating habits. Those are all the items or studies that are areas of study that were looked at by these 6 studies. And what you see in the area above the white area are percentages that are the difference between the person who did those unhealthy activities and the individual who did not. So for instance, in the Yen study, they found that the person who smoked 1 pack a day of cigarettes experienced an average healthcare cost per year that was 51.9% higher than the individual who did not smoke. In the Brink study, they again looked at a different population, used some different methodology, but they found an 18% higher rate for the individual who smokes. The Anderson study showed a 31% higher rate. The Bettera study, a 32% higher rate. The Lee study, 42.8%. Manning study, 11%. So you can see variations occurring. We will look at how large these studies were when we look down in the white area and see the life years in the study. So the larger the number of life years, the more valid the percentage or the data is about the differential use of health services when you actually have that particular risk. And then if you look at the weighted average in that first category, smoking, you can see that what we did was we took the proportion of total life years across all 6 studies, which is the 323,552 life years. That's a lot of life years. The proportion that each of the study represents was then used to weigh the average percentage that showed up in each of the studies. And when you do a weighted average, you're going to get more weight given to the larger studies. And that, in fact, produced a 27.9% average to the smoking behavior. So that's how you would interpret this. Now, if you look at alcohol use, you can see that there are some that are negative. And that basically is an artifact of the methodology that was used. Because one of the things with alcohol use is we know that people who drink a lot tend to die more quickly. So they die out of your sample. And then that basically then causes you to overestimate those that are not in or that are in the sample because you've lost them from the data at a particular time. So there's also the issue that there is some protective effect of low levels of alcohol use. Okay, we're not really quite sure all the mechanisms that are involved, but there is some benefit. And we also have the problem that this is all data that is not anonymous. It was an individual telling his employer that he in fact misuses alcohol. So we know that some of the studies, the Brink and Anderson study, actually underreported alcohol use. So people weren't honest in their responses around alcohol. So those are some of the reasons why you see that. But when you take the weighted average again, you're going to look at about a 10% higher level of cost for the individual who misuses alcohol. The same thing you can see across. And by the way, whenever you see an NA, it just means they didn't look at that particular variable. So those studies were different in their methodology. They did use some different thresholds, although we'll look at some of the common thresholds. But what this group of 6 studies did initially for the field was to give us a much clearer idea that there was an increased cost associated with risk factors. And that if we were going to reduce healthcare costs, one of the ways of doing it that has a long-term effect is to reduce the risk prevalence and the risk severity. And if you look at the white area on the table, life years in the study, again, it shows you what they reported, the proportional years of total life years. That just tells you the proportion that study represents of the entire 323,000. So then you see a 1.0 as being the combination of all the proportional percentages. And then the years of study just show you also the variations that occurred in terms of the length of study. So the longer the study, the better the data, because you've got more life years in it and you've got more opportunities. So there, as you read this chart, the weighted average for 21 years of observational data on 323,552 people showed the weighted average of all of these numbers. Now we're going to compare these numbers in a moment to the HERO study, and you'll get a chance to see how close each of these was to what the HERO study has shown us, and we'll talk more about that in a moment. So this is the table that actually began to formulate in the field of worksite wellness the economic principle that your population needs to have low risk in order to have low cost. The more risk factors you've got in your population, the more cost you're going to encounter. Now, health risk defined, these are the most common thresholds for someone who's at risk. So if you're less than 90% of the time for seatbelt use, you are a high risk individual. If your systolic BP is over 140 millimeters of mercury, you're at high risk. If your diastolic is below or greater than 90, you in fact are at high risk. So each of these is the thresholds which allowed the researchers to then look at healthcare costs and compare the person who was low risk or moderate risk versus high risk. So that's what you have in terms of the major definitions that have shaped those 6 studies and also have shaped the HERO study we're going to look at. Now, we want to step back for a moment and think about the pattern of health plan costs. And its health plan costs are not normally distributed. They are highly skewed. So that means that maybe 30% of the population don't use any health care each year or in a given year. Next year they may be users, but this year they're not. And then the percentage of the population, it starts out fairly low, using a small amount, and then that amount of money that's involved goes up significantly. So that when you look at the end of this chart, the last 5% are going to use maybe 50% of the claims dollars. That's called a very high level of skew in terms of those health plan costs. And we may have an average cost of $10,000. You saw the $13,000 in the previous slide. And that would basically be somewhere on this curve. But that means we've got a lot of people, or a relatively small amount of people actually, that have very high costs, and a lot of people, if you look over here at the bottom, that have very low health costs. So that means that we can't use normal distributions as our approach to the statistical analysis of health plan costs. We have to be aware and carefully use issues which help us determine the average costs. Now, the more people we have in our study, the safer we are in using average costs. And that average costs really kind of tell us something. But the smaller the population, we can have a lot of variation, and that's what allows us not to be able to use small populations under, say, 1,000 lives in our analysis. Utilization's U-shaped curve is this next graphic, and if you take average or the age in years down at the bottom, so that's our bottom axis, and then you take utilization index, and that could be hospital days, it could be physician visits, it could be a composite of prescription drugs and or outpatient surgery or diagnostic testing. It just means any kind of healthcare utilization. The larger issue here is actually a U-shaped curve. It's high in the first months of life, comes down, and then it goes back up again. And it's much higher at the end of life than it is at the beginning of life. And what you'll also see here is the male male has the orange one, and it's lower in the 20 through 44 because women tend to be involved in reproductive function, and that's going to increase their cost. And then what happens as we cross over in the mid-50s, we actually see the male of the species having chronic diseases like heart disease or cancer or respiratory disease secondary to smoking, and our costs begin to be greater than females. Now, at the same time, the male line is going to end earlier than the females because the female actually lives about 5 years on average longer than the male. So their cost does in fact get higher than the male simply because most males end up dying at an earlier age. Their average age of death is earlier. So there's a difference in longevity. But the basic issue that we're dealing with here is there's reasons why we have this kind of pattern occurring. And we need to recognize that utilization is generally in a U-shaped curve, that we need to think about that from that perspective. Now, the HERO study, we're going to take the weighted average from those 6 studies we looked at earlier. That's the 323,552 life years in the study, 21 life years. The Getzel HERO study basically found these numbers. Again, the NA means they didn't look at that particular variable. The comparisons give you an idea of higher and lower. but you can see that they're pretty close in terms of the ballpark they're in. So again, the methodology, by the way, for things like eating habits and cholesterol and alcohol use are heavily due to some of the methodological approaches that were different for the HERO study over the other studies that have been done. Now, the HERO study was good because it basically gave us about 113,000 people, about a third of the number in the entire other 6 studies. So that basically gives us, the fact that this is a pretty large population. It allows us to look at the percentage. And the basic idea here is that we're getting, again, confirmation that there's a relationship between risk factors in populations and higher healthcare costs. Now, health risk, increased health costs. This is the Getzel HERO study. It just shows you the data for the 7 risk factors and the increased annual cost associated with an individual that is high risk versus low or moderate risk. So that just gives you, and again, it's 46,000 people times 3 years of study. The health risk also increased sick leave use. So this is another study performed by another individual, Seth Serksner, and some of his colleagues, and it looks at the impact of behavioral risk, health risk on worker absenteeism. So here we're looking at absenteeism costs and the mental health costs. For instance, if you are either depressed or anxious, you in fact are going to have about 150% higher sick leave usage. If you have back pain, you're going to have 140. If you are stressed on a continuous and chronic basis, 130%. No exercise, about 116% or so. And if you are obese, you in fact are going to experience about 115% higher absenteeism. So this data showed us also that it's not just health plan costs that health risk issues drive, but also sick leave. Here's data which also dealt with the workers' comp. It's from the Health Management Research Center, Dee Eddington and Shirley Musich. And it looks at the relationship of a low overall wellness score. That's what OWS stands for. So that's the individual who has probably 4 or 5 or more risk factors. And they used on average 20 times the amount of workers' compensation costs. That's what that 1,989% higher cost was. So that basically showed us that it's not just the health plan cost and sick leave, it's also workers' comp costs that is shaped by the risk factors one has. And then by the way, the low overall wellness score is a multi-risk factor, which shows you a geometric increase rather than an additive increase. For smoking, it was about 1,200%, so that's about 12 times. Poor health, 8 times. No exercise, 5.5 times. Low life satisfaction, about 2.5 or 3 times. So this, again, was the size of the population was about 3,300 individuals for 4 years of observational data. So this is showing us, again, the relationship to workers' comp cost and showing us that those health risk factors we were looking at in the 6 studies and the HERO study also have parallel relationships with workers' comp costs. Now, this is excess medical costs. This is a little newer data, but excess medical costs due to excess risk. So this is looking at the number of health risk that the individual has, and also the numbers, the n's underneath the number of health risk are the number of people in that particular category. The larger the number, the more validity there is in the differential cost. And what you see here is what's called a dose-related response. The more health risks, the more cost. And when you look at the individual that has 0 health risk and then 7 or more, you're looking at approximately 6 to 8 times the amount of cost. So that's a geometric increase. So this data really helps us understand that there are excess costs that our health plans are experiencing simply because we have a lot of health risks that are in our populations, in our working populations and in our populations for Medicare, Medicaid, Department of Defense, and Veterans Administration. Now, those excess disability costs due to excess risk, 36% of all absence, short-term disability, and workers' comp costs were driven by the individual's risk status. So more than a third of the cost of all sick leave absences, short-term disability, and workers' comp in the study populations was explained by the risk factors the individual had. So if they were low risk, 0 to 2 risk, that set the amount at $491 as a base cost. We then saw an increase in excess coming from the individuals who were non-participants. That's kind of a way of looking at the people who are not even letting us find out what their risk factors are. And then if they were medium risk, they had 3 to 4 risk, it went up to 292. And then if it was high risk, 5 or more risk factors, then the amount was $757. So that's a dose-related response. It just shows the more of the risk factors you have, the higher your absence, STD, and workers' comp illnesses, injuries, not injuries, but absences are. Now, this is additional data from the Health Management Research Center, and it looks at excess presenteeism loss due to excess risk. So here we're looking at the low-risk individuals, 0 to 2 risk factors, about 17,000 people. The medium risk, 3 to 4 risk factors, and that's about 7,000 people. And then the high risk, 5 or more risk, that's about 3,400 people. So these are all actuarially credible populations. And then what you see is the base costs, and then you see excess costs that are driven by the risk factors. And we end up looking at some fairly high percentages increased cost that are associated with those risk factors. This is more of a composite or collective look that looks at, again, a large number of people from multiple employer settings, national sample, and it just identifies how much the cost increases if they in fact increase their risk during the study period. If they took on new risk or actually got a new risk factor, it shows you the average cost increase. And again, it's a dose-related response. And then if the risks are reduced, it also showed you the average reduction that takes place if people did in fact reduce their risk. So this is more smoking gun type of evidence to show you that if we increase the numbers of risk in a population, the cost will go up. If we reduce the number of risk in a population, the cost will go down. So this is the core of the research that's been done around the relationship of health risk and health cost, and it really provides us with a very strong scientific base to the need to have our wellness programs actually help people reduce their health, clinical risk factors, and behavioral risk factors. Now, the likely solution for this long term, we believe, is what's called a risk stratification approach. It's where we have a population at risk, we do a health risk assessment or a well-being assessment or well-being survey. We then can determine which of these strata the individual is in. It shows you also some of the major issues that are in each of those strata. Then it has a set of kind of unique incentives and communication that are designed for each of these strata. And then the idea that there's interventions and different kinds of things that can be done, which you see listed below the dotted line in the boxes at the bottom. So the idea is that ultimately our most efficient way of doing population health management is using a risk stratification model and actually having this kind of thing carried out in terms of population health management. Now, a summary of key points for this particular module include the relationship of health risk to health costs is crucial to the wellness field. If we want to make an economic argument for doing wellness, it comes back to some of the health risk issues we're attempting to deal with. Many early studies have preceded current efforts. The methodology and study quality of these early studies vary significantly, but their results are similar. They are different in magnitude. A few of them are different in direction, but most of them have the same magnitude or the same direction, but may have different magnitudes, which come from the methods and the populations that were used. Health risks are powerful in producing excess health costs, sick leave, disability days, and presenteeism losses. A large number of interrelationships exist between and among the various behavioral and clinical risk factors, and that's the work of Dee Eddington and the Health Management Research Center at University of Michigan. Without intervention, we will naturally move from low risk to high risk. And that's what the data and the work of Dee Eddington essentially has established, is that if you don't do anything, you will get worse. And that's just the natural progression as we age and become less active. Our weight goes up, our dietary patterns get poor or get less than desirable. We end up with a lot of that activity going on. Selected risk can be reduced and will usually produce reductions in cost. And most risks are directly related in increased healthcare costs, but some risks are inversely related. So you saw some of that in the HERO data when we looked at some of the cholesterol issues and some of the nutrition issues and some of the alcohol related use. And a lot of that is embedded and created as artifacts by the methodology used by the researchers. Now, rational approaches to risk stratification will likely be the ultimate approach to deal with changing health risk of defined populations. So we ultimately are going to probably end up doing more of a risk stratification approach. Population health management must deal successfully with health risk prevalence and severity. So we can't leave the health risk issues behind and simply go off toward well-being. If we do that, we're going to end up with growing healthcare costs at very high rates, and we're going to end up with people then having to deal with the economic pressures of that on a business operation, government, and on nonprofits. Now let's look at some key questions. Our first question is, why are health risk and costs so important? And I think it's because healthcare costs have been one of the issues in our society and in the American economy that have been the most out of control for the longest period of time. And that creates an enormous business pressure. So healthcare costs are a big deal. They are a major issue for us. Also, the relationship of health risk to health costs are important because they represent one of the largest ways that we have of reducing healthcare costs and producing a large number of what are called positive externalities, other things that are good for us, like improved productivity or the ability to have a longer work life because we are healthier and don't have chronic conditions. So that's the major reason why this issue is so important, is that this is one of the last areas we have of being able to essentially control healthcare costs or lower their rate of growth over time. It also provides the strongest economic justification for worksite wellness. So my experience has been that all worksite wellness has to have an economic justification to last over the long haul. Otherwise, it gets dumped by the next group of managers who come into a business. So that's why it is so important. And it also provides and allows us to plan, target, and evaluate our results from our wellness efforts. That's another reason why we have to look at this, I believe, as very important to the field and to our efforts. The second question is, what points of reference should be included when we're dealing with health risk and health cost? And I think the major reference points are getting familiar with the literature, a lot of it to D. Eddington and David Anderson and Ron Getzel, that have shown us that if you do nothing, you are likely to be paying a premium for that. So if you don't help people stay low risk, you will in fact pay much more for your health care coverage. That will create more economic pressures on every segment of our society. Also, the relationship, another reference point that I would include is the relationship between our healthcare cost and its size in relation to after-tax profitability. All businesses that are profit making have to look at that issue. They have to look at how much are we spending on healthcare and how much is our after-tax profitability. And if we can reduce or increase our after-tax profitability by reducing healthcare costs, that's a very efficient way of being able to increase profitability. And businesses that are profitable tend to create more wealth for their shareholders, for their employees, for the other stakeholders that have an economic interest in them. So that's another reason, reference point that I think is important for us. I would also include the full 5 economic variables: health plan costs, sick leave, workers' comp, disability, and presenteeism as the measurement points for the economic issue. And I also would like to say another reference point is, as we watch what's happening with our Medicare, Medicaid populations, the repeal activities and the modification activities under the ACA, the Department of Defense, and the Veterans Administration, we need to recognize that if we don't get those costs under control, they will likely have enormous adverse consequences to our economy, to our society. For Medicare, it's estimated that Medicare currently has an unfunded liability of somewhere around $34 trillion up to the year 2030. So our ability to reduce that unfunded liability and take care of that and help our Medicare covered individuals is extremely important. That's another reason why that point of reference needs to be included. In addition, we need to help our citizenry make a transition to a longer work life. Instead of looking at retiring at 55, we need to be moving that retirement age up, because that's what our society needs. And I would probably postulate that that's a healthier thing for our population. I don't think that retirement tends to have very high rates of mortality and morbidity. So we want people to continue to be active, to feel productive, and to have high quality lives. And we also want to optimize our societal disruption, minimize that societal disruption by limiting the amount of chronic disease our population has, the premature mortality or early mortality that comes from health events that are the result of lifestyles that are unhealthy. We have a lot of other, again, what economists call externalities that are also important for us. The third question is, how should this information that we've been sharing in this module be utilized? And I think that we want to get a handle on this as wellness professionals, and we want to be able to brief our senior managers. I think we want to retool our wellness efforts and get a stronger economic base in them, and that's also what we call the move to the results-driven wellness model. So you're dealing more with productivity effects, economic effects, as well as health improvement and value on investment types of considerations. I think that whatever we do in this regard will in fact be a positive development for employers, for employees, for labor unions, for all the different stakeholders that we have across the spectrum of the U.S. population. Now that you completed this particular module, go ahead and take the quiz.